Hi, Claire. I know you're a well-known expert for patellofemoral pain, but still, like, considering my audience is mainly in Asia, can you like introduce yourself a little bit?
Yeah, sure. Well, thank you, first of all, for the invite. It's really kind of you. So my name is Claire Robertson, but a lot of people know me as Claire Patella, which is a bit of a clue. So I'm a physiotherapist, and I have a sort of triangulated work life, which is a second opinion patellofemoral service, which I've run for nearly 20 years, which is patella, fat pad, ITB in essence. Then I'm a researcher in the field, all things patella related. And then my business, Claire Patella, is around education. So primarily physios, but also coaches, SEM docs, chiros, osteos, that kind of thing. So everything patella, right and left, but everything patella.
Nice, nice, nice. So, uh, I feel like, I mean, as a strength coach, I feel like it's hard to differentiate like patella tendon pain and patellofemoral pain. So, can you start by like explaining like what exactly is the difference and how can we like assess it or diagnose it?
Sure, it's a really good question. And of course, you can, of course, at times have a bit of both going on. But there are some really useful clues to help differentiate. So, first of all, if we take the history, which is probably the most useful, it, first of all, it's highly unlikely to get patellar tendinopathy in someone sedentary. So, activity level is more if they're at the sedentary end, would be pushing you towards thinking patellofemoral pain. The way they describe their pain is different. And often the patellofemoral pain patients will use the flat of their hand and they'll sort of rub around the knee and they're a bit vague. That's here, it's kind of there, it's under there, I can't quite get it. Whereas the patellar tendinopathies are often a lot more precise. They'll often point with their finger more precisely. And the most common location is the osseous junction of the distal pole of the patella with the tendon. So that's another clue. Um, it would be extremely rare to get someone with patellar tendinopathy that was happy with sustained static positions. Long journeys, often their tendon feels stiff. In the morning, their tendon feels stiff. We do sometimes see sitting pain with patellofemoral pain patients, but often they won't. So again, that's another useful thing to look at. And then I guess the final thing in terms of our um, history and questioning is around what happens as you do your exercise. So generally with patellofemoral pain, the more you do, the worse it gets. Whereas with patellar tendinopathy, sometimes as they warm up during the session, the tendon performs a bit better. And then they think, oh, I feel fine actually, or it's performing a lot better because the tendon just performs that little bit better. But of course, they then stop and then it gets stiff and sore again. So there's some useful stuff around history taking. So use your questions carefully would be my recommendation. And then if we're talking about our physical examination without imaging, first of all, I guess palpation is the most useful tool, I would say. So feeling for two things, the presence of pain in and around that osseous junction. And to get at it, I press down on the top half of the patella, which elevates the bottom half of the patella like a seesaw. And then you can really get onto that osseous junction of the tendon and the patella. And if they've got patella tendinopathy, they will not like you digging around there. Okay. It is also possible to have it in the mid substance of the tendon or even the distal tendon. So, but the majority it's that proximal tendon. So palpation really helpful there. Um, and then we're looking at also the feel of the tendon, the thickness, the pliability. So in tendinopathy, we get this thickened tendon where the body is trying to heal, throwing down new but poor quality tissue. And over time, the tissue gets thicker and less mobile. So I often come on the side of the tendon and push it sideways to feel if it's pliable. And in a good going tendinopathy, often it feels almost like you're just pushing on a rod. Whereas again, with the patellofemorals, there's less to sort of feel and locate. So
Nice.
they're my main top tips.
Nice, nice, nice. So, so if it what about treatment wise? What would be like what would be the difference between treating a patella tendon and patellofemoral pain?
Yeah, so this is where sometimes clinicians get into trouble, because if you treat somebody with the type of treatment we would look at for tendinopathies, so that would be heavy, slow loading, eccentric loading, maybe using a decline board. Of course, that's very heavy on the front of the knee. So if you've got your diagnosis wrong and they've got patellofemoral pain, they will often get worse. Okay, so in a sense, the treatment for patellar tendinopathy is a bit more narrow and precise in terms of, you might want to look at isometrics for pain relief, the slow heavy resistance, the eccentric training, and really it's all about incremental increase in load over time, and at the same time deloading them from the activities that are winding up the tendinopathy. So unfortunately for a lot of athletes, that is coming off the running, or plyometrics, because you can't just blindly push on with those. You've got to sort of deload those to reload the tendon and then bring it all back together. The patellofemoral pain, it's a very interesting umbrella term. We could have a 15-year-old obese, hypermobile, inactive female, and I could also, in the same clinic, the next patient, have a 65-year-old male ultramarathon runner, and they've both technically got patellofemoral pain. So this is where our clinical reasoning becomes just so important. So really looking at why it came on in the first place, okay? And then looking at their load, their athletic load. And often it's quite polarized. So we often see, and it very much in adolescence as well, either they're just doing nothing or they're doing tons. And if you've got somebody that's patellofemoral pain and they're very athletic, doing huge amounts of load, are we really going to send them off to the gym and add in further load, do a load of squats and lunges? It doesn't add up when you look at the clinical reasoning. So with patellofemoral pain, and to some extent tendinopathy, I like to break it down into intrinsic, extrinsic, and psychosocial. So intrinsic is strength, length, stability. And then they're the things, of course, that I can influence, but I've also got to then look at things that I can't influence, but I need to be aware of, like femoral neck position, more dysplasia at the joint. So have they got a shallow trochlear, for example? Have they got an excessively pronating foot? What is there about their anatomy, in essence? So that's all intrinsic to them. Extrinsic, we've got training load, and even within training load, I'm exploring frequency, intensity across the week, the distribution, rest days, sleep quantity. We've got footwear. We've got what surface are they training on? Stair volume. Sometimes it's as simple as they've moved house into a townhouse or a flat with a load of stairs, and just upping the stair volume is tipped the balance. Kneeling volume, and that often is people that might do jobs that kneel a lot, or say often I find young mums with small children down on the floor a lot, crouching, kneeling. So they're your extrinsic factors. And then the psychosocial loads. So have they had knee pain before and had a bad experience? And so their belief and their expectation is this is going to take a year to fix. Or perhaps are they on a sports scholarship and they're under huge pressure? And if they are, is the pressure coming from the school, from themselves, from the parents? So looking at all of those factors, And this is why people say to me, God, don't you get bored just doing patellofemoral pain? And I'm like, no, it's so interesting because there's always like being a detective and you're looking at all of these factors and then you're trying to make the treatment as bespoke as you can. And it's interesting, running a second opinion service. So everyone I see has had failed treatment. And I would say the number one gripe, if you like, from the patients is they were just given a generic list of knee exercises, didn't feel that they could relate to it at all, didn't feel that it was bespoke to them at all, and still didn't know really why their knee was hurting. So I spend a lot of time going through sort of sense making, actually, saying, okay, let's explore why your knee is sore, what's changed. Because if we look at the health beliefs literature, it shows us that when people have traumatic injury like an ACL rupture, it's really clear, okay, you've had a big ski wipeout, you've ruptured your ACL, this is the course of events, this is probably the time frame. But when people have insidious onset symptoms, whether it's headaches or abdominal pain or patellofemoral pain, they don't know why is my knee suddenly hurting? And if you can't help them make sense of that, they are less likely to engage with their treatment.
Nice, nice.
I'll stop talking now.
No, 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 no. That was awesome. That was awesome. Because uh so as you know, I work with basketball my whole
Yes,
life. And we have a lot of anterior knee pain.
I'm sure.
And so this is actually interesting because if you ask some of the biomechanists, they'll be like a lot of the anterior knee pain is actually um patellofemoral pain.
Yeah,
But if you ask the same question to tendon expert, they'll say a lot of it is actually patellar tendon pain,
yeah.
right?
Of course, you've got fat pad as well.
Yeah, yeah. So so I mean the same group of athlete, but ask different people, they have like different opinion.
Yeah,
So I guess my follow-up question is like you say, you run a second opinion clinic. Am I using the right term?
yeah, exactly. Yeah.
So how exactly do you like figure out what are we dealing with?
Yeah, well, the starting point has to be that diagnosis. And really, I do like to have some imaging as well. So, MRI is a good sort of overall catch all. It gives us a snapshot of if there's anything else we may have missed. But with respect to the patellofemoral joint, I'm particularly interested in perhaps our younger athletic patients. Is there a chondral flap? Is there an osteochondral defect, like a hole with edema around it? Um, and yeah, they're the main two things in this young athletic population from a patellofemoral perspective. And then on MRI as well, of course, we're going to get a snapshot of whether this tendon looks thicker, looks bigger. And then really, if we're wanting to look at the tendon in more detail, then we can use ultrasound to really to measure the tendon, and we can use Doppler to see whether we've got angiogenesis, lots of new vessels, which of course is a clue that we may well have tendinopathy. Of course, to throw a little red herring in here, we also have to be aware if you take very sporty people that do a jumping sport and you scan them, you will find often that they have thickened patellar tendons. And this is why, yes, imaging is useful, but it is absolutely not a replacement for good examination, because otherwise you might say, well, tendon's a bit thick and white, I'll treat them for tendinopathy. But actually, if you really listen to them and just heard how they describe their pain in a more vague distribution, or maybe they've got a catching pain on stair descent, it might give you some clues that actually, yes, they've got a bit of a thickened tendon on MRI, but really it's presenting much more like patellofemoral pain.
Mm. So another question is like a lot of time we do heavy, slow, eccentric or isometric for patellar tendon,
Yeah.
or at least someone says patellar tendinopathy. And what happens if they have like sharp pain while doing the ISO or while doing the heavy slow is eccentric?
Yeah, so I would say, first of all, the main role of the isometrics is pain relief. So it ain't working if you're doing it and they're getting a lot of pain. That's just going wrong somewhere. I'm a really big fan of exploring angles, and I often find you just change the knee angle. It can be either way, a little bit more extended, a little bit more flexed, and do the isometric. You can completely change the pain profiles. So before you kind of write it off and go, well, that's not working, it is worth just tweaking the angles. I'm not too much of a fan of sharp pain. I think there's two reasons. I'm always slightly concerned in tendinopathy, we might be thinking, okay, are we creating a little tear in the tendon? And we clearly don't want that. But also, we know that sharp pain creates a huge inhibition of the quads. So we're not going to get good quads activation and force generation in the presence of sharp pain. So a bit of, oh, that's a bit uncomfortable. Fine, let's work through that with the patellar tendinopathies. But if it's then hang on, let's just explore this.
Nice, nice. All right. Since you brought up quad, a lot of anterior knee pain, like people say because their VMO is not activated.
Yeah, okay.
Yes, I know, I know. So share me your thought about it. That's why I asked the question.
Okay, yeah, so a lot to say about this. So this really is quite a historical thing. So when people started researching patellofemoral pain back in the kind of, I suppose, 1980s, people thought everyone with patellofemoral pain had a VMO problem. That's why they got patellofemoral pain. So it kind of got a head start in the literature race, if you like. So that is why there is a lot of literature on it. Then we roll on to the 2004, 2005. There was still a debate going on. Is the VMO even a thing? And there were a couple of cadaveric papers, one by Ono, one by Peeler, that came out really in quick succession. One said, yes, it is. One said, no, it isn't. But they were really very small cadaveric papers, sort of n equals 5. So at this point, I thought this is absolutely ridiculous. And I spoke to a colleague of mine. At that time, I was in academia, and I spoke to a clinical anatomist and said, right, we have a thing to answer here. So we ultrasounded 80 knees to put this to bed. And we found, yes, the VMO is a separate entity from the VML. And there's a fascial plane between the two. They originate off different muscles, different fiber angle. But we weren't saying you can activate the VMO in isolation compared to the VML. And this is where I think people have gone wrong, is they've been banging that drum. And actually, there is no evidence to suggest you can recruit it in isolation. But when we set out to describe the anatomy, something very unexpected and curious happened. And that was that we found some people had a VMO fiber angle. We measured it relative to the femur. Some people had an angle of around 40 degrees, and some people it was around about 70 degrees. And we also noticed that some people only had a third of their patella with the VMO attachment. And some people it was right down to about 95% of the medial wall of the patella. So I said to Phil, my colleague, there's a question to be asked here, and that is, does this depend on how athletic you are? So we then did another study where we scored them with a Tegner score, and we found a really tight correlation. So if you're sedentary, you have a small angle and a small amount of attachment. And if you're more athletic, you have a bigger fiber angle and a bigger insertion. So then at this point, this started to look really quite interesting. So I said, okay, the next question is, can we manipulate this? So we then took the sedentary people, we put them on a training program, and we watched what happened to their architecture. And we were measuring this with ultrasound, so it's accurate. And sure enough, their muscle fiber angle changed, and so did their insertion ratio. And actually, you know, panaceal angle, fiber angle change isn't a new concept, but no one had ever looked at it in the VMO. So we've subsequently done a lot of studies, and these are all published, and there's links to all of these on my website. But in essence, we've shown you can manipulate the fiber angle with exercise. And so when we're doing quads exercise, we don't even need to think of it as VMO exercises. But as long as we're doing quads exercise, as long as we're doing it to fatigue, and at least 2 to 3 times a week, we will get a change in the muscle architecture. And that will be a better medializing force onto the patella.
Nice, nice. So, um, we talk about exercise for patella tendinopathy. What about exercise for patellofemoral pain?
Yeah. So there are depends what we're finding, but what we know from the literature is that proximal exercises on the glutes, particularly gluteus medius as an abductor and as a rotator, and quads exercises, if you look at the efficacy, it comes out about the same. So if I have someone with a really sore, irritable knee, really I'm struggling to get in and do anything meaningful, I'll say, okay, let's start up at the pelvis. Let's look at strength up around the pelvis and start. Then we can dominate and isolate that by doing, open chain stuff. We can still make that hard. We can do something like a side plank with top leg lifts. It doesn't have to be easy peasy just because it's open chain. And then really we do, of course, want that quad strength because we want that decent VMO architecture. I'll circle back to that in a minute, but we've also got flexibility issues potentially. Tight calf encourages excessive pronation. It encourages early heel rise in the gait cycle. Loss of hip flexor length will again encourage the heel to come up early and the knee to flex more in our walkers and runners. So we've got if we've got high tone in the quads, that's just going to create a compression in knee flexion. And if we've got high tone in TFL, glute max, that's going to influence the patella via the ITB. So I'm still a fan of looking, and it's not as in vogue at the moment, but I'm still a fan of looking at flexibility. And then circling back to quads, we've got this issue at times. It's very common where you think, okay, I know they need to get strong. I can see they need to get strong, but their knee's really irritable. How am I going to do this? And there's a few tricks that I would really recommend people think about. So again, the first one is angles. So if we take closed chain, first of all, if I stand up straight and I flex my knees and come down into a squat, as I come lower and lower, the patellofemoral pressure goes up, and everyone can feel that on themselves. But the relationship is not linear. So what happens is the patellofemoral load goes up, but it goes up quite slowly until 50 degrees. Then between 50 and 90, it starts really escalating, ramping up. And then when you get past 90, we've got almost an exponential growth in patellofemoral pressure. So what I often choose to do is say to people, right, we're going to take some of our sort of typical closed chain movements, maybe some squats, lunges, split squats, Bulgarians, whatever. But I will say, okay, I'm going to really load it up with weight, but I'm only going to do it from 0 to 50, as opposed to unloaded with no weight, banging down to 90 degrees. And then we can get some overload of the muscle and we can induce some fatigue. Otherwise, if we go down to 90, often they just get sore. They're not doing anything enough to fatigue the muscle, so you've not achieved that goal. So really thinking about angles, there's a caveat to that, and that's that open chain is the opposite. So if we think about the leg extension machine, from 90 to 45, the load on the patella goes up, but relatively slowly. And then from 45 degrees to 0, again, it really shoots up. So I might say say in a gym setting, let's do leg extension 90 to 45, and let's do leg press 0 to 45. So we are getting some muscle activation in different parts of the range. But by doing this, we can load the weight up a bit more to get that muscle fatigue without the overload on the joint.
Nice, nice. A follow-up question is, um, we're talking about anterior knee pain. We're talking about patella tendon. Uh, why is I think there's more and more research or more and more people talk about calf, talk about hip, talk about ankle while we're dealing with anterior knee pain.
Yeah, it's really important, and I would be looking at the foot and ankle on all of my patients. I think we've got to look at it from two elements. One is the movement will follow the path of least resistance. So if we have a restriction at the ankle joint, say we've got an old ankle sprain and it's left the joint a little bit stiff, or we've got a tight calf that still also blocks or restricts dorsiflexion. As I said before, we've got that excess pronation, we've got that early heel rise. But we also know that if we've got the foot driving down to excess pronation, it encourages bad firing patterns proximally. So then it encourages the whole limb to be dropping into medial collapse, into that sort of unwanted valgus position. And then the final thing about the foot and ankle for people to bear in mind is I ask every single patient any ankle injuries at all, because what often that will happen is they won't tell you that they had an ankle sprain last year because it's gone, they've kind of almost forgotten about it. But when you ask them, they then go, oh yeah, funny you asked about that. Just before my knee started hurting, I had an ankle injury. And what I think happens is if we look at the literature, we know that ankle injury inhibits the ipsilateral glute med. And we know that glute med function is super important for the patellofemoral joint. So I think even if the ankle movement is restored normally, sometimes they're left with this legacy of this sluggish glute med that's either weak or its rate of force development slow. So they've dropped in before glute med's fully activated. So ask every single patient. And in line with that, ask every single patient about back pain, because back pain inhibits glute max. And again, glute max is a really important femoral rotator. And if you don't ask, they don't tell you generally. And it's amazing, honestly, when you start asking, it's like so many patients will say, yeah, my back was really bad a few months ago.
So when you treat the anterior knee pain, no matter patella tendinopathy or patella tendon, but sorry, patella femoral pain, we're basically treating the whole lower limb or even the whole body.
Yeah, absolutely. The whole body, I would say. And Lee Harrington's done some really nice work on qualitative assessment of single leg loading. So this might be in an irritable knee, just single stance. It could be a single leg squat, or it might be a single leg hop. And what I say when I teach is basically the message from his work is, where's the wobble? So in other words, is it all arm strategy and the arms are flying around? Or actually, is that okay, but the trunk's moving around a lot as they're doing these maneuvers? Or actually, is that all fine, but the pelvis is dropping around? That might be fine. It might be the femur spinning around, or it might be the foot. Because I don't want to receive a letter from a clinician just saying unsteady in single stance. I want to see a second half to that sentence. I want to see unsteady in single stance driven by poor trunk control. Because also then to sell it to the patient, you've got to send them off with some trunk exercises. And they need to know, why the hell am I doing trunk exercises when it's for my knee pain?
So early on our conversation, we brought up fat pad, and fat pad is another thing that like I think more and more, maybe because we learn more or know more about all these stuff, so more and more physical therapists or AT gonna talk, athletic trainer gonna talk about fat pad. So how is it gonna like affect the knee pain, and what's the difference between those two?
Yeah, it's quite different again. So a few things about the fat. So we're talking about Hoffer's infrapatellar fat pad. So under the patella. So The fat pad has more nerve endings than any other structure in the knee. So when it's inflamed, it really hurts. This is the thing that has people crying in my clinic room. You know, it's not just, oh, it's a bit sore. This is the thing that, you know, means people just can't. Some of my patients are almost housebound. It's so incredibly painful. So we're looking at pain levels. They often will describe it as a background ache that is there 24/7. And that is because it's an inflammatory scenario, whereas our tendinopathy and our patellofemorals is much more mechanical. You know, I do this, it stresses it, I stop, it's fine. So they've got this background ache, and then often they will report sharp, awful, like they often say dagger-like, glass-like, really nipping, terrible, sharp pain with certain movements. And those movements are typically movements of extension. So we know that the fat pad has the least space between 0 and 30. So therefore, the fat pad should deform in that range. But if it's inflamed and hence therefore bigger, it just can't deform. It's already filled the space. So when they go to move in that range, it pinches. And that's why typically you're going to find your fat pads hate standing, prolonged standing. They hate walking. Whereas standing and walking really shouldn't be a problem for someone with certainly the patellofemoral pain. And with patella tendon, and I'd only expect the standing to be a problem if it was a very long hours. So really look out for that totally different description of pain and movements of extension. And please don't encourage them to use the leg extension machine if they've got a fat pad problem. It will just make it 100 times worse.
So I guess what would be the assessment for if it's a fat pad?
Yeah, so the first things are the questioning, which we just talked about. Then we're looking at what does it physically look like. You know, when they're inflamed, they are bigger. And sometimes it's the whole fat pad. And sometimes it has what I think it's like frog's eyes appearance. You get these two big round bulges either side of the patella tendon, like a pair of frog's eyes. And sometimes, though, interestingly, it's just one side of the fat pad that's inflamed. And if I'm seeing that, I'm immediately thinking, okay, I need to look at horizontal plane control here, whether it's from the foot, the femur, because it's basically sort of overloading one side of the fat pad. So I'm looking at, I'm looking for size, I'm looking for tenderness. And they also sometimes tip into neuropathic symptoms. So that's your abnormal response to light touch. So this is the patient that comes in a pair of shorts even when it's snowing, you know. And I ask all my fat pad patients 2 questions. Does it ever go weird colors? Purple, red, blotchy? And if they say, yeah, it does actually, then I say, have you got a photo? And sometimes, often they'll have a photo. And if you're seeing that, that's a big clue of neuropathic involvement. And then I'll also say, how are you with the feeling of fabric? Trousers, the duvet? And if they say, oh, no, don't like it, that's a clue as well. And the fat pads tip into neuropathic involvement much quicker than the tendinopathies and the patellofemorals. So that's something to have on our radar. Going back to physical examination, I'm also going to be looking at carefully at extension. If I've got someone with a raging fat pad, I don't need to overpress their extension and make them even more sore. You know, by now I should have realized I'm dealing with a fat pad. If it's someone that's very subtle symptoms and I'm querying whether it's tendon or fat pad, then yeah, sure, I might overpress their extension, and I might even do a Hoffer's test and compress their Hoffer's fat pad, but you don't normally need to be honest. And some of them just won't even let you anywhere near their terminal extension.
So if you can't do leg extension, you can't do extension. What's the exercise treatment for fat pad?
Yeah, so I really see it in 2 very distinct phases. The first is you've got to settle it off because it's an inflamed structure. And if you try and push through it, it's just like blowing on the fire. So I'm giving all my top tips right now. I have 3 go-tos really. One is ice massage, either with an ice cube, or I'm really sad, I've actually invented something for this. It's called Ice It Away, and it's like a little ball with ice. So 2 to 3 minutes of ice massage to oiled skin to the fat pad every 2 to 3 hours. We know fat pad patients have more blood flow. That has been demonstrated. So that vasoconstriction from ice is incredibly useful. It helps make them, they love it. It's pain relieving, but also if it's slimmer because it's got less blood in it, then it's less likely to impinge. So that's my first thing. Second thing, taping. This is the group I tape the most to offload the fat pad. And they'll often stand up and go, oh, that's nice. So, and then I'll just say if they can tolerate the tape, back to back, wall to wall taping, 2 weeks to really try and break them out of that inflamed cycle. And then I often will go either for a trainer with a maximum heel drop, or even more, a trainer with a big heel drop with a heel raise inside, because when we tip forwards, we open up the space for the fat pad. And a complete ban on barefoot, flip-flops, Converse, slippers, anything dead flat, again, for about 2 weeks. And then the final thing is to avoid, as life permits, prolonged standing or more walking than necessary. You know, just walk for what you need to, but cap it at that, just in that initial phase. Because then if we position them at 2 or 3 weeks where, okay, this is much less sore, less big, you know, then we can start getting in and strengthening. But I wouldn't be strengthening them between 0 and 30 or more than 90 until their fat pad symptoms have gone. So I start between 30 and 90. And then, of course, the final piece in the picture is always the question, why did it come on in the first place? And sometimes it's obvious, they've had a big fall, whacked it, or someone's run into them, or whatever. But if there isn't an obvious cause, what's going on here? Is it they're hypermobile and they actually, as they go up the stairs, they flick their knee into hyperextension and patella bangs against their fat pad? Or that they've taken a new, I had someone recently, she'd taken a new job, so there was a waitress, stood all day, and as she's fatigued, her knee drifted into more hyperextension and was just aggravating the fat pad. Or these asymmetrical fat pads, is it that they're just rolling in and perhaps they're a distance runner and at the end of the run, they've really fatigued glute med and they've got more femoral rotation at the end of the run, their knees are knocking and they're squishing their lateral fat pad. So again, putting your detective hat on, working out, because if you don't deal with that, that is probably going to come back.
Last question before I let you go. Uh, what about needling the tendon when it comes to like tendinopathy?
Needling.
Yeah.
Okay, do you mean like dry needling or
Yeah.
injectable treatments? Dry
Dry
needling.
needling, dry needling.
Yeah, I mean, look, the literature body it doesn't particularly support that. I think look, some patients report that they get relief from it, and also some patients get relief from dry needling of, you know, the muscle belly. So I'm not against it. You know, I think they can be really, really tricky to treat. So sometimes you have to think a bit laterally, but it's not a substitute. I suppose that's my most important message. Something like that is an adjunct. It's not a replacement for our exercise-based treatment, which is the only thing really. Even if you look at all the shockwave, you know, GTN patches, PRP, the literature body is pretty weak around those. So the best supported treatment is exercise. But we can look to some of these other things as adjuncts. So I think we just have to make sure that the patient understands that this isn't instead of the exercise.
Nice, nice. All right, so before I let you go, uh, for all those who are interested in what we're talking about today, or like they're struggling with figure out like what are they dealing with, where can they find like where can they find you? I know you have a lot of resource. You have your own website and online courses. Where can they find those
Yeah.
information?
So the best place to head for is my website. So www.clairepatella.com. Um, and I guess the other thing to say is, I'm happy to do in-service trainings with physios or trainers remotely. I do that quite a lot now. So people want to get a group of them together and, do an hour's session. That's another thing we can do. And we can chip off one area specifically, whether it's, patellar instability or adolescent patellofemoral pain or fat pad or whatever. As long as it's patella related.
Nice, nice.
Yes. I hope, but look, there's lots of free resources for patients and for patients and clinicians on the website. So that's the best starting point.
Nice. Thank you. That's all the question I have for today.
Oh, well, I hope that's been useful to you and your listeners, Eric.
Thank you.
All right. Thanks so much for asking me on. I really appreciate it.
Yeah, thank you. I know you're super busy, so I'm gonna let you go.
Okay.
But
Thanks so much. All right. Take
bye.
care. Bye.